Hello, sir. Good
Hello.
evening, sir.
Very good evening.
I'm Ankita from Karnool Medical College, AP, sir.
I'm from Andhra Pradesh, so I understand where Kannur is.
Dr. Sharmil, sir, resident doctor of Cardiothoracic and Vascular Surgery, 6 years course at Sir Gangaram Hospital at New Delhi. Sir, have been guiding interested aspirants since the last few years. Sir, it's wonderful to have you here, sir. Thank you so much
It's
giving
nice to be
some
here.
time out of Thank you so much for giving some time out of your extremely busy schedule to guide our students, sir.
That's fine. That's fine.
Here, I wanted to take this opportunity to ask you some questions more from students' perspective about early career perspective, how you achieved your career, and what you might have message for us, sir.
Fine. Let's go.
Yes, sir. So, can you give us some general introduction about this branch, sir?
See, general introduction, there is nothing much to say. This is a branch which deals with the cardiothoracic and vascular system, which means that we deal with the heart, we deal with the lungs,
Yes.
and we also deal with the vascular system. In the recent times, although the specialty itself says the cardiothoracic and vascular, most of the institutes where this course is conducted will give a broad perspective of cardiac surgery, a little bit of thoracic, but most places won't have exposure to the vascular surgery. So it will be very little to no exposure at all. Because vascular surgery itself has developed into a super specialty in the recent times. So that could be one of the reasons why this is happening, but that's how it is. Although you will eventually get the course, you will get the degree of cardiothoracic and vascular surgery per se.
Yes, sir. So, can you explain us the life of a resident, sir?
There is nothing much to explain. There is the residency is just like any other residency. This is a surgical residency, so it's a little bit hectic. Most places they start operating early in the morning, say around 8 in the morning. So you will be there by 8 in the morning, 7:30 possibly, sometimes, to finish the rounds before you actually, the OT begins. There will be
Yes.
places like ours where we start at around 9. We don't start till 9, so you can. It's a little easygoing institute hours. So that's another perspective. But your day ends usually when you are, especially a first year, your day ends only when the OT is over. So it could be 4 in the evening, it could be 4 the next morning. It all depends on when your OT is finished.
Oh,
On an average, in a private institute, you will be handling about 4 admissions a day, most of and about the same number of discharges. The first year itself is mostly in most of the institutes, as I have been listening since yesterday. Most of the institutes have the general surgery training in the first 9 months or 6 months or whatever. And after that, once you come back to your home department, the first year usually is for you to learn the ward work. There are certain places where you are allowed to the OT even during the first year. One of those places is our institute. We usually take even our first years into the OT, provided they do their ward work very nicely. Uh, Other than that, as you grow in seniority, your responsibility obviously increases. It does not decrease, obviously, for obvious reasons. And as you grow in seniority and as your responsibility increases, I mean, it could be that your number of night duties and all might come down, but I think then you'll still be supposed to stay back till the OTs are over. So that's the sort of a thing that cardiac surgery has.
so the things you love about being in specific specialty, sir.
In this specialty, I was talking to certain students. Some of them are here right now, join this meet also. The best thing that I like about cardiothoracic surgery is the fact that it's a very good amalgamation of both your clinical skills, your operative skills, as well as technology. This is the branch in which you can literally stop and restart the heart. So you basically make the patient dead, operate upon him, and then bring him back to life. And that was probably the reason why most of the cardiothoracic surgeons, say in 2000s, had used to have this God complex because they used to believe they could restart the heart after stopping it. So that's something that I really love about it. The other thing that I like about this specialty is that it allows me to stay in touch with the medicine. It allows me to stay in touch with the cardiology part. I do not have to forget about the cardiology part. I do not have to always rely upon the cardiologist to, manage my medications, to, treat certain patients who are post-operative and have come to me with, say, some problem of, say, heart failure or certain other issues related to the heart. I can handle them all by myself. That's other freedom that I get. The third thing is I think this is the only surgical super specialty where you also learn the ICU care. There is no other super specialty where you will be handling your own ICU. Not neurosurgery. As far as I understand, plastics and pediatrics तो बात ही नहीं होती. They are different. This is a different ball game together. So you can always handle the ICU. You can learn the hemodynamics and how everything's work in the ICU as well. These are a few things I absolutely love about this specialty.
So, sir, can you tell us about the cons of being in your specialty, sir?
One of the biggest cons of being in cardiothoracic surgery is a very long learning curve that it has. So you are not
Oh,
looking at an independent career even after your 6 year residency. You still have to do some sort of a fellowship. If not a fellowship, then you're looking at working with somebody else, trying to hone your skills for good 3, 4 years. So that makes it about a 10-year long curve for you to even start thinking about independent practice. Some of my seniors did start their career, I think, in couple of years after they passed out, but I still feel that they were more of an exception than the general rule. The general rule of thumb would be that you would be, in a sort of a resident position for about 10 years or so. If not as a resident, first 6 years as a resident, then maybe 3, 4 years as a fellow.
so, sir, I personally want to be a cardiothoracic surgeon, sir. So, what personality type should be best fit in this branch, sir?
I am not sure if the personality has anything to do with any speciality per se. I think it's more of you could be of any personality, but I think you should be more willing to be uh, adjust yourself to the branch. I think that's one of the first and foremost reasons in this. I think the best way to go about any residency is you should have some interest in the branch first of all. If you do not have any interest, if you're choosing it just as a backup or just because you got it, it makes life a little more difficult irrespective of whatever personality it is. In general, what I would say is a person who wants to go into cardiothoracic surgery has to be mentally very tough. It cannot be, this is
Yes,
not a
sir.
branch uh, because of its long learning curve, and also because uh, this branch has no mercy per se. It's a very unforgiving branch. You can take a stitch wrong and you can kill the patient. And you might be doing everything right, and you might still have massive bleeding occurring on the table when you're trying to do a basic procedure. Those things cannot shake you off. Those things cannot put you off. You have to come back and do the same thing again in about an
Yes,
hour,
sir.
maybe 4 hours time. But those are the things. And secondly, cardiothoracic surgery, the surgeries are pretty long. So the physical strength has also a lot of meaning here. So I mean that's the sort of a thing. And if also that also something that I would like to point out is I think most of the cardiothoracic surgeons will have their work-life balance completely screwed. You will be spending a lot of time in the hospital because your surgeries. If you're doing 2 surgeries a day, that means you're spending at least 12 hours in the hospital, if not more. This I say because your surgery might last just 4 hours, but the patient to be prepared, it takes about 45 minutes. The patient to shifted, that takes another 45 minutes. Then, the OT gets ready and you get the second patient in, that's another half an hour. So eventually, you end up spending good 12, 13 hours in the hospital on a normal day. And God forbid if you have complicated something. If something you have complicated, then that's a completely different story. Or if you are doing certain surgeries, say there are certain aortic surgeries that are done in cardiothoracic surgery, which sometimes can take hell lot of a time because it just bleeds. I mean, there could be no reason, but they just bleed. I mean, it's aorta. I mean, it's aorta, and it just says, "I'm aorta. I'm going to
Yes.
bleed." So you can't do anything about it. You're still standing in the OT, you know, keeping the sponges, standing there, doing basically nothing. But you still stand in the OT sometimes the whole night. There is nothing that can you can do about it. That's the sort of specialty this is. So if this is a specialty where sometimes you go in thinking this is a 2 hour surgery and you might not end up coming out till the next day. So you need to be mentally and physically tough as far as this is concerned. And as I said, I don't think a personality makes a difference. You could be of any personality type, but I think it's more of your interest towards the subject and your interest in surgery per se that's going to keep you kicking.
That's good explanation, sir. Which type of personality will reject this branch, sir?
I think again it's the same thing. I mean, whoever does not like, this sort of working hours, who do not like cardiothoracic, the cardiac system per se. I mean, they cannot simply survive. The other problem that I see with 6 year courses, I was dealing with this yesterday also, is the fact that a lot of you people who will choose 6 year courses right after MBBS are you have not been exposed to these super specialties per se. Most of you at least would not have been exposed to these specialties. So what happens is whenever you choose a 6 year course, you get overwhelmed. You get into the department, you're standing there and somebody, I mean, two senior people talking to each other, and it might simply sound gibberish to you. You may not understand a word of what is being spoken, even though they are speaking in English. That overwhelms you. You come in and you suddenly see so that's one thing. The second thing is you might come in and on day one you might see somebody going into the OT at 8 a.m. in the 8 a.m. and not coming out till the next day. That can simply put you off. That can scare the hell out of you. I mean, if this is the sort of life
Yes,
that I'm
sir.
going to live, yeah. So these are the sort of things that happen, and these are the sort of things that will put people off. And I think these things, if they scare you, I mean, obviously you should not be roaming anywhere near cardiothoracic surgery. This is one field which does not have any guarantees of what your day will be like.
Big versus small city, government hospital, corporate hospital.
See, in general, both government hospitals and the corporate hospitals have this facility. Corporate hospitals seem to have a little more facilities than the government hospitals, that's for sure. As far as big city versus small city is concerned, right now the major and the more complicated procedures are being done only in the metros. Nobody, even in tier two cities, is attempting more of the complicated procedures because they are more or less trying to establish themselves in the first place. So they would not try to, and the second problem is also the fact that a lot of patients who are advised complicated procedures, they do not trust the surgeons in the tier two cities as well. That is also a problem and an issue. So these people can also, sort of come to metro cities and get operated. So I believe that most of the cardiothoracic surgery, even in coming times, would be still focused on tier one and tier two cities only. I don't believe tier three cities will get much of a chance. And even if they're going to do very minor procedures, mostly thoracic, I believe. Again, not cardiac. Because as soon as a cardiac surgery is advised, most of the patients, they start rushing towards metros. I have seen patients, since I'm in Delhi, I see patients coming from Patna very often. I mean, it's like 14 hours journey, but people still travel to Delhi rather than getting operated in Patna, even though Patna has competent cardiothoracic surgeons. So that's a thing, and eventually I think it will also depend on how you practice, how you show cause your skills, and how you win the trust of the patients there in whichever city that you are in. That will also matter eventually. That will also need to be, sort of considered.
Average years to settle in this branch.
I've already answered that, about 10 years at least. And after that, it also depends on the number of years that you require to acquire your basic skills, and then add to them and get to an advanced level. Uh, Ideally, when you join as an independent consultant, you should be able to tackle any and all of the complicated cases. So that's the time that it's going to take. At least 6 years of residency and another 3, 4 years for sure. On an average, that's the time I feel.
So, sir, can you explain about the monetary aspects, sir?
The monetary aspect, see, I think if you are going to go for whichever state, it will depend on the state in which you want to, settle down. And it also depends on where you want to settle down. So, is it a government institute or is it going to be a private institute? Are you joining a particular consultant? Where are you going to join? All these things are eventually going to matter. So, if you're going to join a government institute, the most probable post that you will get is an SR. Now, there was a question yesterday when somebody asked, even after doing my DNB, do I need to do SR-ship? It might not be necessary, but it might be the only post that might be available because the positions for the both assistant as well as the associate professors, they do not come out too often. They come out maybe 2 or 3 years, once in 2 or 3 years, and it will depend on number of professors retiring in that year and all that stuff. Getting that? So the government positions may or may not be open for you, and if you go to the government sector, then you are looking at most probably looking at an SR job. That's one thing. Once you come to the private sector, if you're going to join the medical college, you may be looking at an assistant professor professorship. Then you are looking at whatever the scale of the assistant professor is in that particular state. Because even if it is a private medical college, it's not going to pay you well above that scale. They're going to at least hold you to that level. So whatever is the salary of an assistant professor for other specialties, that will be what you'll be earning. That's about the government sector. As far as the private sector is completely concerned, so if you go to corporate sector hospitals, there are jobs available there also. There could be, they usually what they do is they'll give you a position of clinical associate to start with, then elevate you to junior consultant at about 2.5, maybe 3 years. And eventually, if you stay at the same place, you may be promoted as a consultant in next 3 years or so. So that's how it is. As far as the salaries are concerned, again, it will depend on which state and with whom you are, operating and talking about. So in Delhi, the salaries vary. So the salaries in Delhi, I can comment upon Delhi because I'm living in Delhi. I will not comment upon other states because I do not have much idea about them anyway. So in Delhi, if you join a government sector hospital, the scale for an SR is about 1.2, 1.3 lakhs. As an assistant professor, if you join a medical college, I think it's about 1.8 lakhs. Then in private sector, if you join, the salary varies according to your skills. So it will also depend on how well your mentors put you to the other people also because the cardiothoracic surgeons mostly they know each other. So if I tell them that I've done my DNB from Gangaram, they will call one of my teachers and ask me, how is this guy? What can he do? So somebody has to vouch for my skills. And once that is vouched for, then you are looking at a salary upwards of 1.5. Some of my seniors started working at 1.5 last year. So I'm thinking this year one of my seniors got placed at 1.8 lakhs in Delhi in a corporate sector hospital. So I think 6 years down the line you're looking at a higher number anyways.
So, sir, is there any free time for other stuff, sir, while being resident and after settlement, sir?
See, while being a resident, I mean, I find time because I like to, get away from the field from time to time. I will not say that there is absolutely no time. That's not actually what happens. I usually find some time, you know, here and there. And whenever I find some time, I'll just go away from the hospital. I'll just go watch a movie. Every 3 months or so, I like to take a break. So I'll just take a holiday. I'll go for 3, 4 days. I may not go anywhere per se. I may just lie in my bed and do nothing. But that's what I'll do. I'll take a break every 3 months or so because it becomes very tiring. It becomes very tiring
Yes.
mentally for me. And I'm someone who feels that. I mean, that burnout and stuff. So I like to take my days off. I don't mind because I have 30 days in my kitty. I don't mind. I'll take a 3, 4 day break somewhere. I'll go, I'll travel someplace. I'll meet my friends. I'll do something. I'll keep myself fresh. So there is always time if you have, but you have to find it. And you need to have people who understand that you can be late and lunch plans might not always be feasible, but dinner plans are always possible. I have to take my dinner anyways. So if even if I'm leaving by 8:30, I might meet somebody at 9 and have my dinner with them, have a little chat, catch a beer, that sort of stuff.
So,
So there is some time you can pursue certain hobbies, that sort of stuff.
so, sir, the future of the growth and takeover by other specialties, sir.
Yes, that's something that is of concern to a lot of people. A lot of people have an understanding that cardiology is going to take over completely the cardiac surgery, and cardiac surgery is a dying branch. As one of my mentors, Dr. Shad, his he always says that people who have initially said that the cardiac surgery is going to die have died, but the cardiac surgery has not died yet. So I don't think the cardiac surgery is going to die. What is going to happen for sure is that you're going to handle more complex cases. You are not going to handle, so your generation, which means it includes me, I mean, our generation is not going to handle simple cases. We are going to handle more complex cases because cardiology will have its own say. They will grow, they will produce more and more percutaneous procedures, and people will start preferring it more and more because a cut which is a 10-inch long cut is not acceptable to the patients when compared to a needle prick. So that's what is going to happen. But that means that we will handle a lot more complex cases than our previous generations have. So our teachers, whatever the complexities that, whatever cases that they think are very complex, are going to be the norm for us eventually. So this is, I'm talking about 10 years, 15 years down the line. The second thing that I think about cardiothoracic surgery, why am I saying why cardiac surgery won't die? It's there is a particular reason. So adult cardiac surgery, yes, I mean coronary artery bypass graftings may reduce over a period of time. People might still keep doing stents and whatnot, but pediatrics, congenital heart diseases, you may treat an ASD with a device, you may treat a VSD with a device. How are you going to treat a
Yes,
transposition of
sir.
great arteries with a device? It's simply impossible. It's not possible to treat transposition of great arteries with a device. It's not possible to have a complex AV canal defect to just put a device and ha ha be merry. That's not going to happen. So all these cases need to be dealt with. So as I said, these are more complex congenital cases. Exactly like the complex congenital, there will be more complex adult cases as well. Certain valves which may not be doable by the percutaneous thing, so they'll all come to you. There is also a certain set of patients who have undergone surgeries as children, congenital patients who underwent surgeries as children. They'll grow up. These people will have certain complications. One of the complications that is expected in patients who are undergoing surgery for transposition of great arteries right now is aortic aneurysms. So these people are going to come to you for getting these surgeries done. And it will be a complex surgery because the child has already undergone surgery, so it will be a redo surgery. So that's the complexity behind it. These will be complex cases, but I don't think there is any lack of future. The other specialty that is taking a lot of what do you call as uh, limelight currently, especially in India, is heart failure surgeries. So heart failure surgeries means there are certain devices called as ventricular assist devices, putting them in, taking them out, ECMO, mechanical circulatory support in its entirety, and heart transplants. Heart transplants as well as heart and lung transplants. Heart and lung transplants are not a big thing right now in India, but
Yes.
it is expected that in next 10 to 15 years, as the donors will increase, they'll also take root, they'll also grow. Right now, the cost is a little too high. In South, they are doing a lot of heart transplants. Not a lot, I would say, but still they are doing good numbers. In North, it has not yet taken root much. So that's something to look forward as well. Lot of options as far as cardiothoracic surgery is concerned.
Can you please tell about the super specialization and fellowships, sir?
So, cardiothoracic surgery can be divided into lot of subspecialties: adult cardiac surgery, pediatric cardiac surgery, thoracic surgery, and vascular surgery as well. So, you might want to do cardiothoracic and vascular surgery, and then eventually want to drift off completely to vascular surgery. There are fellowships available to do that as well. Thoracic surgery fellowships are available. As far as congenital cardiac surgery is concerned, absolutely. There are fellowships available all over the world. There are three fellowships available in India. Apart from that, there are at least, I mean, you name it, there are a lot of good fellowships all over the world. Adult can be further subspecialized. So, adult will have subspecialized and fellowships in coronaries, coronary surgeries. That's one subspecialty of adults. Valvular heart disease has is another subspecialty. So there is a recent trend of not replacing a valve rather than trying to repair it, irrespective of the condition of the valve. So that's something. Then there is minimal invasive option in all of these. And as I just said, heart failure surgeries and mechanical circulatory support is another way.
So,
All of these are subspecialties in their own and have fellowships of their own. So and they vary from 1 year to 3 years with an option to extend.
sir, what are the things to be considered for choosing a college for this branch, sir?
For choosing an institute, what I would want all of you to consider is whether you'll have adequate pediatric exposure or not. Why this is important is because when you go and give your exams, when you go and give your final exams, most of the time you will face cases only from the adult and the congenital part. Most of the institutes even do not ask you about thoracic. So if even thoracic exposure is less, that's fine. If vascular exposure is not there, that's acceptable. But if pediatric exposure is absolutely zero, I think that's a bit of a problem for me. If you're at least if the institute does not have it, they have to send you to some other place to have an exposure. If they're not doing it, I mean, it's a simply no. Don't take that institute because it will be a problem. And as and when you will take this branch, or if you just want to scroll through, I mean, download any textbook of cardiothoracic surgery and start scrolling through the topics, you will find that the adult cardiothoracic has 5 topics and congenital has 25. Okay, so that disproportionate is there, and you have to also understand that as far as cardiothoracic surgery is concerned, the congenital surgery is the senior person in the cardiothoracic surgery. Adult surgery came later. Congenital surgery developed earlier. Congenital developed in 50s. Adult cardiothoracic surgery only started developing in 70s and 80s. So it's a much younger branch. So so that's the thing. So you would want to know your congenital very well. So you need that exposure from pediatrics. If they have good exposure to thoracic and if there is a good vascular department, it's absolutely fantastic. If they do not have it, if they have an average exposure of thoracic, that's fine. But without congenital, I think it will be a little difficult.
So, sir, in giving surgeries, is there any gender bias, sir? It's my personal question.
No, there is no gender bias that I have heard of till now. But again, each surgeon might feel a little different. Each surgeon might feel a little bit different, but till now I have not heard of it. And if I'm not wrong, if I'm not wrong, in the last 2 years at least 45-50% of the candidates who are opting for cardiothoracic surgery are girls. So I don't see it as a problem if a girl takes it up. The only issue that you might have to look at is how you're going to manage your partners along with this. You need to have partners who are understanding, and that
Yes,
goes for boys as well. Okay, it's not just the girls. I mean, even if the boys, I mean, you're going to spend if you're going to spend all of your time in the hospital, I mean, even the girls will leave you for sure. क्योंकि घर तो आते नहीं हो क्या करोगे वहीं रह लो. So that's the sort of a problem. That is the only matter that you need to sort out in the hospital. I don't think it's that big a problem, Most of the surgeons, and at least in current times, I don't think it would be a problem.
So, sir, any special message from your side, sir?
No, no special message, nothing special from my side. All I want you people to do is be very sure about whatever brand that you're choosing, whether it be 6 years, whether it be 3 years. You need to have some liking for the branch. You need to have some, if not the branch, because if you're not exposed to the branch, you need to have at least some liking for the system that you are going to handle. You hate nervous system and you take up neurosurgery, you will not survive. You will simply not survive. You may develop a liking. That's one theory. A lot of people put it forward, but I don't see it happening a lot. I think you need to have at least some interest in the field before you actually get in and start learning. Uh, Over a period of time, interest develop ho jayega is a theory which I do not understand. What is I? It's just a matter of probability. What is the possibility of you taking up something that you already like versus what is the possibility of you taking up something that you completely hate, which is a better possibility. So I feel that if you like something a little, at least that would help you cope with whatever problems that might arise. Uh, yeah, that's about it.
So, what keeps you motivated to pursue your goals, sir?
What keeps me motivated to pursue my goal? See, the thing is, when I was in my MBBS, I was exposed to vascular surgery a lot. Uh, that was because I used to spend a lot of time outside of my classes with surgeons. I was always interested in surgery. I wanted to learn. And I wanted a head start from others. Okay. I did not want to do it when I was in MS. I wanted to do it when I was in MBBS. So I used to go to the hospital, spend a lot of time with surgeons. I got exposed to vascular surgery a lot. And from there, I think in general, I had a liking for the cardiovascular system because cardiovascular system I find is one of the most logical systems that is there in the body. Brain, there is a lot of things that people do not understand about it. There is nothing about heart that people do not understand. Everything about it is more or less understood. So you are never going to say, I do not understand why did this happen. That answer comes out very rarely from your mouth. You can always, if you cannot pinpoint the reason, at least you'll have a broad reason in your mind why something went wrong, why something went south. That's one of the reasons why I like cardiovascular system per se very much. So I put two and two together because I like cardiovascular system together and I like surgery very much. So just opted for cardiothoracic surgery, and I never had anything else in my mind. To be truthful, I mean, even when I took DNB cardiothoracic surgery, I had options of taking MS General, MS ENT in AIMS Delhi. I dropped out of there. I didn't take MS in AIMS I opted for a DNB 6 year course. Uh, I was going to, thankfully, then my girlfriend, now my wife, she asked me a simple question. She said, if I have ever spoken to you, the only thing I have heard from your mouth is cardiothoracic surgery. You're saying I'm going to opt for MSENT. Are you going to be fine with it? That was the only question she asked. And I turned around. I said, no, I'm not going to take MSENT. I'll go for cardiothoracic surgery in DNB. And I just took it and I never looked back. I like it very much when people get in touch with people, know what they're getting into, and then opt for things. Rather than getting into it blind, if you have a perspective, if you understand what you're getting into, it makes your life a lot easier. And I've been trying to do that for the past 2 years. And yeah, I mean, it has worked as far as I can see. There are a lot of people that have been in touch with me. I sometimes teach. There is a lot of stuff going on like that. That's that's something that's something nice that we have put together. And it's also a good thing because what happens is that allows me to be in touch with almost all the institutions across the nation. So we are in touch with each other. So we know what is happening with each other. We are friends. So that's sort of a group that we have formed, which is very nice. Most of us know each other. So that's something of a generality in cardiothoracic surgery per se. Most of the consultants, they know each other across the
Yes.
country. People know each other. It's not like they don't know each other. They might not speak to each other every day. But if I put my resume somewhere in South, my consultants will definitely receive a call and ask, and they'll get asked, okay, we have received a resume from so and so. How good is he? How bad is he?
So,
And one thing very, very clearly, it's not just about cardiothoracic surgery. This is about any medical specialty that you're going to do in India, and then you're thinking of settling outside. Let me be very clear, no specialty that you have done in India is recognized outside India, whether it be a DNB, whether it be an MD, MS, or whatever. There are certain exclusions which are made by certain people at a certain level. So this is an exception sort of a thing. This is not the general rule. As a general rule of thumb, you have to understand no specialty that you have completed in India is valid specialty outside of India. So you have to do something to support it. So the other misconception that a lot of people have is that if you do an MRCS and FRCS, that's not related to. Yeah, Solani, I'll get back to that question now. You could have opened the mic and answered. You questioned me, but you still choose to type and make my life difficult. Anyways, so so MRCS and FRCS. What people who are doing the residency in England, what they give, and what you give, they have different nominations. Okay, so they are not they are उनका नाम ही अलग है थोड़ा सा. So what happens is even if you complete it, what it gives you is it gives you a right to possibly enter GMC in England without having to appear for additional exams. But that does not mean that you will be guaranteed a job there. Most of the times you will go there as a fellow. Okay, to go as a fellow to UK and Australia, New Zealand, you do not need to give any additional exams. Most of the centers in UK and most of the centers in Australia and New Zealand, they will accept whatever specialty that you have done. If you have cleared your exams, if you have a degree in your hand, if you have a 6 year experience, they'll accept it and accept you for a fellowship. What is the flip side of going like that? The flip side of going like that is you cannot stay back over the period of your fellowship because you do not have a valid qualification in Australia, New Zealand, or UK. Okay, so how do we do it? One way of doing it is you write USMLE. USMLE is now universally accepted. It's accepted in UK as well nowadays. It has recently, I think, some bill has been passed, and now what I understand is USMLE is an accepted qualifying sort of a thing for UK also and Australia, New Zealand also. So once you give your MLE, it makes your life a lot more easier. So there are a lot of Southeast Asian countries where you can do your fellowships. Uh, Again, if you have done your MRCS or FRCS, there you will have the chance to work as consultants and whatnot. So the countries I'm talking about is Malaysia, Indonesia, and Singapore. These are three very good places to do fellowships as well. US, of course, is a wonderful place to do your fellowships. So you would want to keep that option also open. So I would suggest that you give your MLE. But again, even after doing your MLE, if you go there, you do your fellowship, you cannot stay back because you have not done your residency in US. And if you want to stay back in US and practice there, most of the times they'll ask you to redo your entire residency again, which will be of 6 years. There is a back door there is a back door, but to get through that back door, you'll need the support of the director of the fellowship program and a very strong support on that. If he does not support you that much that he's willing to sort of push you through that back door, there is no other way to stay back in US or Australia or wherever. You have to complete your residency in that particular country again. That's the issue with going outside. You can go outside
వద్దులే.
for you go outside to do your fellowship for 3 years, 4 years, but that's about it. You will not be able to stay back and practice as a consultant over there. That's the problem with going out. and it is a problem for all the countries, not just USA. Am I clear? Have I not? I hope I have not confused you all with what I said.
It's clear, sir.
Right. So, Saloni, difficulty of the exam, I believe, is always proportional to your preparation. You prepare well for your exams, you read well, you are well prepared. I don't think there is an examiner who can fail you. At least as far as cardiothoracic surgery is concerned, I have conducted exams very recently also in my institute for students. The examiners that come, they are not looking to fail you unless you give them a chance to fail you. You don't go into an exam and start talking rubbish. Unless if you go into an exam and you start talking rubbish, you are done for. I'm telling this to you. There have been candidates who have appeared in exams with me or in in one of the centers that I know of, where a candidate went, examined the patient, diagnosed the patient completely wrong, misdiagnosed the patient clinically, and yet he cleared the exam. Mainly because even though he misdiagnosed the patient clinically, his line of thought was very, very clear. He could explain why he diagnosed it as what he's diagnosed it, and then he was very clear about how he's going to handle that diagnosis. So they were sure that this boy is not going to kill a patient. And as long as they are sure that you are not going to kill a patient, they won't fail you. As far as cardiothoracic surgery is concerned, the passing rates for the last 3-4 years has been around 80%. So every 4 out of 5 candidates pass. I do not comment upon other specialities. Certain specialities have dismal rates, but not cardiothoracic surgery. Cardiothoracic surgery has very good passing rates. So unless you're trying to fail, you will not fail.
DNB 6 years CTVS in Delhi College, except Gangaram. Many say that their setup is not good. Kindly enlighten on that point.
Okay, so right now Delhi has, if I'm not wrong, at least 6 institutes. One is Gangaram, BL Kapoor is the second, Fortis Escorts is the third, National Heart Institute is fourth, Apollo Indraprasth Apollo is fifth, and Delhi Heart and Lung is the sixth institute. Of these, the only institute where I'm not sure about the setup is Delhi Heart and Lung. About That's the only institute I'm not sure about the setup. Rest 5 institutes, all of them have very good corporate setups. Gangaram has a good corporate setup. Max Saket, and Max Saket, of course. Max Saket has a very good corporate setup. They have a good pediatric program as well. Indraprastha Apollo is two great surgeons are there. Adult, there is Dr. Babadas, and then in pediatrics, there is Rajesh Sharma. Dr. Rajesh Sharma is one of the leading pediatric cardiac surgeons in Asia, if not in the world. So that's a completely different level program. Although they started taking in only last year, so people who are going to, enter now is going to be the second batch, and your senior is just 3-4 months old. But that should not deter you from taking that hospital. It is an excellent program because the consultants there are absolutely brilliant. Then Fortis Escorts again is a good setup, no questions about it. BL Kapoor is a corporate setup, completely good setup. National Heart Institute is a good setup. I don't see I don't think there is any problem with the setups in Delhi. The problem in Delhi is academics. We do not have any strong academic program, any of the institutes. Not even in Gangaram, we do not have a very strong academic program. It's on and off sort of programs that we have in academics. So it goes on sometimes, and suddenly it goes off for 3-4 months, 5 months, and suddenly somebody else wakes up and gets it going for about a month or two, and then again it stops. That's the problem with the Delhi. I'm trying to sort it out, but that's that's this that's the problem. So, Mayur, I was asked if the setups in Delhi were okay. I'm saying that the setups in Delhi are okay. You learn, the exposure is okay. The problem is with the academics, but that will be taken care of. I think I'll think of something. I'm already working on a few things. I stopped because I had certain work commitments, but I think I'll get back to it as soon as this month is over. I have to finish my thesis this month. Once that is done, I think I'll go back and finish. Anything else? No? Can we stop?
Definitely, sir. Again, you have enlightened about especially that Delhi colleges and the things how they work and it's whether it's good or not. You enlightened us very uh, particularly about each institute. So thank you so much. Thank you so much again from Team KYC, sir. So
Thank you all for having me.
yes, sir. With due permission, we can end this session.
Yes, yes, please do.
Okay. Thank you, sir. Thank
Okay.
you.
Good night, all of you. See you all soon. Bye.
Thank you so much, sir.